Welcome to the Deep Dive. This is where we take the source materials you send us, your curiosity, and really dig into them to pull out the key information.
That's the plan.
Today, we're doing a pretty comprehensive exploration of the thyroid gland, that major player in your endocrine system.
Absolutely.
We've got this detailed medical text you shared, and that's going to be our guide. We're aiming to cover, pretty much everything from how it normally works to the really surprising range of abnormalities and tumors that can pop up. Our mission really is to take all this complex stuff and make it clear, engaging, and hopefully genuinely useful for you.
Exactly. And the thyroid, that butterfly-shaped gland sitting there in your noke, it's remarkable, not just for its vital role in metabolism, which everyone sort of knows about, but also for this huge spectrum of conditions it can develop.
Right.
And thyroid issues, as you probably know, are pretty common. A frequent worry is nodules, these little lumps. So you can think of the thyroid maybe like a landscape with lots of bumps and lumps. And our goal in this deep dive is to help you understand that landscape, to get a sense of what's normal, what's just a minor variation, and what might be that rare needle in the haystack that needs a closer look.
Needle in the haystack, I like that. And our source really takes us on a journey, doesn't it? Starts right at the beginning, thyroid development, these sort of molecular directors guiding it.
Yeah, the transcription factor.
Exactly. Then moves through things like benign enlargements, inflammations, all the way to, a whole spectrum of tumors. Some are quite tame, others like anaplastic carcinoma, among the most aggressive cancers known.
It's a huge range.
It really highlights the diagnostic puzzles the thyroid can throw up sometimes. So let's dive in, right at the beginning. Normal anatomy and development.
Okay. Well, even the name thyroid, as the source points out, comes from Greek. Thyrios, meaning shield, and eidos, meaning shape. Kind of fits its look.
A shield shape, makes sense.
And it's crucial to remember it's one of the largest endocrine organs in the body. It makes hormones that regulate just a massive range of bodily functions.
And its development is, it sounds incredibly precise, managed by this team of molecular transcription factors, you call them, like master architects, making sure it forms correctly early on.
That's a good way to put it. The key players mentioned are TTF1, that's also NKX2-1, then TTF2, or FOXY1, PALSate, HEGX, and NKX25. These basically tell the genes what to do, switching them on or off to guide how the thyroid forms.
Fascinating, like a molecular construction crew.
Pretty much. And once it's formed, its function, its ability to actually work, relies on a few things. There's thyrotropin, or TSH, that's the signal for the pituitary gland.
Okay.
Its receptor, TSHR, which is on the thyroid cells waiting for that signal.
Right.
And then a downstream molecule called GAZA. Think of that as the messenger inside the cell that carries TSH's instructions.
So signal, receiver, messenger.
Exactly. And the source points out that if any of these components get disrupted, it can lead to thyroid dysgenesis. It's kind of a broad term for defects in how the organ develops. Interestingly, genetic changes, mutations in the TSH receptor gene itself can cause these problems, even outside of bigger syndromes. And issues with that Greason gene are also involved. So right from the get-go, genetics plays a huge role in the thyroid even forming and functioning.
So even before birth, little genetic hiccups can have pretty big consequences down the line. Okay, let's move to congenital abnormalities then. Structural issues present from birth. The source mentions thyroglossal duct anomalies first.
Yeah, these are interesting. They come from the thyroglossal duct. That's a temporary tube that exists when we're developing as embryos, and it normally just disappears.
But sometimes it doesn't.
Exactly. If it sticks around, it can show up in a couple of ways. Either as a sinus tract, like a little channel that might open somewhere between the base of the tongue and lower down the neck, sometimes near the breastbone.
Okay.
Or just as a closed-off, fluid-filled tube.
And that leads to thyroglossal duct cysts, like swellings from fluid buildup.
Precisely. Fluid accumulates in that leftover duct. The text notes they usually pop up right in the midline of the neck, often near the hyoid bone, that little horseshoe-shaped bone in your throat.
I know the one.
And under the microscope, these cysts have a specific lining. It can be pseudostratified, ciliated epithelium, looks a bit like airway lining with tiny hairs, or squamous epithelium, more like skin lining. Importantly, the cells lining these often test positive for TTF1, that developmental factor we mentioned, but negative for thyroglobulin, which is key for making thyroid hormone. It's pretty common to find mucus glands, even some thyroid follicles, the basic working units in the tissue around the cyst. And understandably, these cysts often get inflamed.
Makes sense. Another one is heterotopic thyroid tissue. Thyroid tissue basically turning up where it shouldn't.
Yeah, thyroid tissue in unexpected places along the path that thyroglossal duct took way back during development. The source lists quite a few spots. Well, the anterior tongue, that's called lingual thyroid. The submandibular region, under the jaw. Larynx, trachea, the mediastinum, that space between the lungs, upper or lower parts, and even, believe it or not, the heart.
Wow, the heart.
Yeah, and the source points out most of these odd locations fall into what's known as the Wolfler area.
And that lingual thyroid, the one on the tongue, is particularly important, isn't it? The text says in, 70% of cases, the normal thyroid gland isn't there.
Exactly. So if you find a lingual thyroid and remove it thinking it's just extra tissue, you could actually cause hypothyroidism because that might be the only thyroid tissue the person has.
That's a crucial point.
And another thing, this ectopic tissue isn't immune to problems. It can develop cancer, usually papillary carcinoma, which we'll definitely talk more about.
Okay.
The good news, though, is that if a tumor develops in this ectopic tissue, surgically removing it usually leads to an excellent prognosis, even without touching a normal thyroid if one exists elsewhere.
Good to know. Now, the text also mentions some, intrathyroidal findings of uncertain clinical significance. Things found inside the thyroid that aren't necessarily a problem.
Right. Little surprises pathologists might stumble upon. Things like small pockets of fat, maybe tiny islands of mature cartilage thought to be leftovers from embryonic branchial pouches.
Cartilage inside the thyroid.
Yeah, weird, right? Also, ectopic thymus tissue, parathyroid tissue, bits of skeletal muscle, even salivary gland tissue or pancreatic tissue. The pancreatic tissue is possibly a remnant from the early gut development.
That's quite a collection of unexpected guests.
It is. Then there's black thyroid or melanosis thyroidy. Sounds dramatic.
It does. What's that?
It refers to this buildup of a pigment, looks like melanin, inside the follicular cells. You see it more in older folks, and it can become really noticeable after using certain drugs, especially the antibiotic minocycline.
So the gland can actually look black.
If there's enough pigment, yes, it can look black to the naked eye during surgery or autopsy.
Wow. Okay, and lastly in this congenital section, solid cell rests, remnants of the ultimobranchial body. More embryonic leftovers.
Exactly, more developmental remnants. These are interesting because they're thought to be the origin point for certain types of thyroid tumors, particularly medullary carcinoma, which comes from the C cells, a different cell type in the thyroid. We'll definitely circle back to that one.
Okay, fascinating stuff on origins and structural quirks. Let's share now to thyroiditis, inflammation of the thyroid. First up, acute thyroiditis.
Right. Acute thyroiditis is usually infectious. The source links it to infections nearby, like in the upper respiratory tract, a bad cold or sore throat, or the digestive tract. It can also happen with widespread infections, sepsis, or even after trauma to the neck.
Who tends to get it?
It often affects people with weakened immune systems, malnourished infants, the elderly, or immunocompromised individuals. The usual culprits are bacteria like Streptococcus hemolyticus and Staphylococcus aureus.
Common bacteria.
Yeah, but other bacteria, fungi like Candida, even pneumocystis can cause it, especially in those with compromised immunity. Viral causes are rare, but the text mentions cytomegalovirus in AIDS patients.
And what's happening inside the tissue, microscopically?
You see neutrophils, those white blood cells that rush in for bacterial infections infiltrating the tissue. There's also tissue necrosis, meaning thyroid cells are dying. Sometimes it can even form an abscess, a pocket of pus. And there's an interesting point about recurrent acute spiritive thyroiditis, especially on the left side. It might be linked to something called a piriform sinus fistula.
A fistula, like an abnormal connection.
Exactly, believed to be another embryonic remnant, this time from the ultimobranchial body.
How do doctors figure this out, diagnose it?
Well, for the acute thyroiditis itself, a fine needle biopsy is key. Look at the cells under the microscope. See the neutrophils, maybe culture for bacteria.
Okay.
If they suspect that piriform sinus fistula is causing recurrent infections, a barium swallow study, where you drink barium liquid visible on X-ray, can help visualize that tract.
Got it. Okay, next type. Granulomatous thyroiditis, or decurvain thyroiditis. Often painful, right?
That's the one. It's subacute, so the onset is a bit more gradual than acute thyroiditis, but yeah, often quite painful and tender in the thyroid area. The exact cause isn't totally clear, but it frequently follows a non-bacterial upper respiratory infection, like a virus.
So likely viral.
A viral trigger is often suspected based on the pattern, though pinning down a specific virus in every case is tough.
And what's the key sign under the microscope?
Granulomas. These are collections of immune cells, macrophages, giant cells that form in certain kinds of inflammation. In deep veins, these granulomas are typically found centered on or replacing the thyroid follicles.
The little hormone-producing units.
Exactly.
The source also quickly mentions palpation thyroiditis. Sounds like poking the thyroid too hard.
Huh. Sort of. Palpation thyroiditis or multifocal granulomatous folliculitis is usually considered clinically insignificant. Just a mild, localized reaction may be triggered by physical handling, even a vigorous exam.
Okay. Now, a big category. Autoimmune thyroiditis. This includes lymphocytic and Hashimoto thyroiditis. This is the immune system attacking the thyroid itself, right?
Precisely. It's a breakdown of immune tolerance. Both antibodies, the humoral side targeting thyroid proteins, and immune cells, the cellular side directly attacking the tissue, are involved.
What kind of targets?
Autoantibodies against key things like thyroglobulin and the TSH receptor are common. Plus, you get infiltration by T and B lymphocytes and cytokines. Those immune signaling molecules are involved, keeping the inflammation going.
What might trigger it?
The text suggests things like infections or injury to thyroid cells could kick it off, maybe by exposing or changing thyroid antigens in a way that activates these self-reactive immune cells. But genetics plays a big role too. Specific gene variations are linked to higher risk for both Graves' disease and Hashimoto's.
And what's the common thread microscopically in these autoimmune types?
The main thing is lymphocytic infiltration. Lots of lymphocytes hanging out in the thyroid tissue, often forming germinal centers, those active areas where B cells multiply.
Okay, but how do you tell lymphocytic thyroiditis apart from Hashimoto's then?
The source suggests differentiating based on how much damage there is to the thyroid parenchyma, the functional tissue. In lymphocytic thyroiditis, you see the lymphocytes, but the follicles and overall structure aren't too badly damaged.
Right.
Hashimoto's, originally called struma lymphomatosa, shows much more extensive destruction and damage. The text advises against using the terms interchangeably, as the appearance often correlates with the patient's thyroid function.
And Hashimoto's often affects women over 40. What does it look like clinically and pathologically?
Clinically, yes, often women over 40. It usually presents as a diffuse, firm enlargement, a goiter, sometimes big enough to cause pressure symptoms like trouble swallowing. Functionally, they might initially have mild hyperthyroidism as hormones leak from damaged cells, but it usually progresses to hypothyroidism under active thyroid. Surgically, the gland usually separates easily from neck structures, unlike Riedel's. Grossly, it's diffusely enlarged, firm, maybe a bit nodular, yellowish-gray cut surface, sometimes looks like a lymph node. Usually no obvious colloid necrosis or calcification. Ultrasound typically shows reduced echogenicity. It looks darker.
And under the microscope for Hashimoto's?
You see those prominent lymphoid follicles with germinal centers we mentioned. You see atrophic, shrunken thyroid follicles. And many remaining follicles are lined by these distinctive oncocytic cells or Hurthly cells.
Hurthly cells. What are those again?
Big cells, pink granular cytoplasm packed with mitochondria. Their nuclei can sometimes look a bit enlarged or dark too. You also often see squamous nests and duct-like structures. That's metaplasia, cells changing type due to chronic inflammation. Rarely, even little cysts lined by squamous cells.
Wow.
And there's a variant, nodular Hashimoto's, where you see distinct hyperplastic nodules mixed in with the Hashimoto's changes.
Okay, then there's Riedel thyroiditis, described as extremely rare and severe.
Extremely rare, yeah. Affects adults, elderly, maybe slightly more women. Presents with this ill-defined, really hard thyroid enlargement. Often causes shortness of breath because it compresses the trachea.
Like an iron collar.
That's the description used. It can bind all the neck tissues together, making it feel rock hard, often mistaken for cancer clinically. But unlike de Quervain's, there's no preceding pain or tenderness, and lymph nodes usually aren't involved.
What does it look like?
Grossly, it's often asymmetric, maybe just one area stony hard. Dense fibrous tissue extends out into muscles, obliterating normal tissue planes, making surgery super difficult.
And microscopically?
Areas of complete destruction alternate with near-normal areas. You see inflamed veins, obliterative phlebitis, and lots of plasma cells, staining positive for IgG4.
Ah, IgG4-related disease. That connection is important.
Yes. Riedel's is now seen as a classic manifestation of IgG4-related disease, a systemic condition causing fibrosis in various organs. It's crucial to differentiate it from other thyroiditis, cancer. Treatment might involve steroids early on, maybe surgery just to relieve compression, but full resection is tough.
Got it. And one more thyroiditis. Multifocal fibrosing thyroiditis. Uncommon but distinctive.
Yeah, this one's interesting. Characterized by multiple small, star-shaped or sometimes band-like areas of fibrosis scattered through the gland, usually only about 3 millimeters across.
Okay.
On low power under the scope, they can sometimes look a bit like tiny papillary cancers. But higher power shows a fibrous, low-cell center merging into a more cellular edge. No actual cancer cells forming glands.
But it can look worrying.
The follicles trapped at the edges can show reactive changes, some atypia that might mimic malignancy, so careful examination is key. You might see tiny follicles with hardly any colloid in the center, too.
All right, so that's a tour through the different kinds of thyroid inflammation. Let's move to hyperplasia, now enlargement due to more cells. How is this classified?
The text breaks it down by cause, microscopic look, and clinical presentation. 3 main types highlighted. First, dyshormonogenetic goiter.
Dyshormonogenetic, meaning problems making hormones due to genetics.
Exactly. It's thyroid enlargement because of inherited defects in making thyroid hormones. It accounts for about 20% of congenital hypothyroidism being hypothyroid from birth.
What kind of defects?
Mutations in genes controlling crucial steps. Getting iodide into the cell, attaching it to precursors, making the main thyroglobulin protein, recycling iodine, usually autosomal recessive inheritance, sometimes linked to other issues like deafness and Pendred syndrome.
Well, what does the gland look like?
Grossly enlarged, multinodular. Microscopically, the nodules are hypercellular, packed with cells, varied patterns, solid, tiny follicles, even papillary or insular patterns, sometimes seen in cancer. Fibrosis is common, can even look like it's invading the capsule.
Anything else distinctive?
A key feature is marked nuclear atypia, weird-looking nuclei, but mainly between the nodules. And because TSH is constantly stimulating the gland, trying to get hormones made, you see lots of mitosis, cells dividing. The specific pattern can even hint at the underlying genetic defect, which is useful for counseling.
Okay. Second type of hypoplasia, Graves' disease, or diffuse toxic goiter, the autoimmune hyperthyroidism one.
That's the one. Autoimmune disorder, where the body makes antibodies, thyroid-stimulating immunoglobulins, or TSIs, that activate the TSH receptor.
So they mimic TSH.
Exactly. Fooling the thyroid into overproducing hormones, causing hyperthyroidism. You also get immune cell infiltration, T cells, B cells, antigen-presenting cells, and cytokines that keep the inflammation going and change how the follicular cells behave. Other antibodies like anti-TPO are often present, but they aren't the main driver of the hyperthyroidism. Electron microscopy might show immune complex deposits. Both genetics and environment likely play a role, but the exact triggers aren't fully mapped out.
And it's the most common cause of hyperthyroidism.
Yep, about 80% in places with enough iodine. Important to distinguish hyperthyroidism, the overproduction from thyrotoxicosis, the broader clinical state of being hypermetabolic, which can have other causes too.
Right. The source lists other causes?
Yeah, things like toxic sporadic goiters from TSH receptor mutations, toxic adenomas or rare carcinomas, TSH-secreting pituitary tumors, certain pregnancy-related tumors, thyroid tissue and ovarian teratomas, stromovaria, iodine-induced hyperthyroidism, other genetic non-autoimmune forms, and issues caused by the drug amiodarone.
What about Graves' and cancer risk? Is there a link?
It's a bit controversial. Small incidental papillary cancers are sometimes found in thyroids removed for Graves. But overall incidence doesn't seem much higher than in the general population with nodules.
Okay.
Most are small, clinically minor. Some studies hint that if cancer does occur with Graves, it might be slightly more aggressive, but it's debated.
How is Graves treated?
Anti-thyroid drugs, radioactive iodine to destroy thyroid tissue, or subtotal thyroidectomy removing most of the gland. That surgery gives pathologists the most common Graves specimens. Pre-op treatment can change the microscopic look a bit, but the underlying features usually persist. There's a risk of hypothyroidism after surgery, especially with lots of lymphocytes or Hürthle cells, and Graves can be part of wider autoimmune syndromes.
Got it. Okay, the last hyperplasia type, nodular hyperplasia, also called multinodular goiter, adenomatoid goiter. This is the most common thyroid issue overall.
That's what the source says, yes. Its development seems linked to things like iodine deficiency, but the cause of sporadic goiter, the kind common in iodine-sufficient areas, isn't totally clear.
What are some suggested factors?
Maybe mild iodine deficiency still plays a role, subtle hormone synthesis problems, exposure to goitrogens, things that block hormone production, smoking, maybe lack of selenium or iron. TSH levels are usually normal. Interesting. It can also occur with Hashimoto's, the nodular forms. There's a hereditary link too, likely polygenic, involving multiple genes. Certain genetic syndromes like Dicer-1 increase risk.
What does it look like grossly?
Enlarged gland, often distorted shape, maybe one lobe bigger. Capsule is stretched but usually intact. Cut surface shows multiple nodules, varying sizes, mostly not encapsulated. Secondary changes like bleeding, calcification, cysts are really common within the nodules.
Okay, so that covers the non-neoplastic conditions pretty thoroughly. Now let's get into the tumors, often the main concern with a thyroid nodule.
Right. The vast majority are primary, starting in the thyroid and epithelial, coming from the follicular cells or C cells. Broadly, benign adenomas and malignant carcinomas. Medullary carcinoma from C cells is kind of its own category.
So based on cell origin.
Yeah, you've got 1, tumors with follicular cell differentiation, benign and malignant. 2, tumors with C cell differentiation, medullary carcinoma. 3, rare ones with both. And those follicular cell tumors, they make up over 95% of all thyroid neoplasms.
Okay, let's start with the benign one. Follicular adenoma. What defines it?
It's benign, encapsulated, shows follicular cell differentiation. The key is no invasion into the capsule or surrounding tissue, and it lacks those specific nuclear features of papillary carcinoma.
How common is it?
Pretty common, usually found in adults with normal thyroid function who have a lump.
Yeah.
Typically cold on an iodine scan, doesn't take up much iodine.
Are there different types?
Yes, several subtypes based on architecture and cell features. Colloid-rich, cellular, trabecular, oncocytic, or Hurley cell, atypical pleomorphic. Even rare ones with clear cells, signet ring cells, spindle cells, papillary hyperplasia, or solid cell rests.
Any particularly unusual ones?
2 mentioned are hyalinizing trabeculoadenoma, distinctive pattern, can rarely metastasize like a low-grade cancer and black adenoma with heavily pigmented cells.
What about the genetics of these adenomas?
They're usually clonal, from one altered cell. Chromosomal abnormality is pretty common, 35–65%, some overlapping with follicular carcinoma. Specific translocations involving genes like ZNF331 and the TCHA are seen in about 10% of adenomas, less often in carcinomas. A TCHA fusion gene is found in about 5% of adenomas, and also some follicular variant papillary cancers NIFTP. The PI3K-PTEN8 pathway isn't often hit in sporadic adenomas, unlike in Cowden syndrome, where PTEN mutations cause multiple adenomas. They can also occur in Carney complex or McCune-Albright syndrome.
And immunohistochemistry, staining.
They usually stain positive for thyroid markers, thyroglobulin, TPO, TTF1, PX8, negative for calcitonin. Other markers like HbME1, galectin-3, CK19 can be variable, sometimes seen in both benign and malignant lesions.
How are they treated?
Surgical removal, usually lobectomy, removing the affected lobe. Just scooping out the nodule and nucleation isn't recommended. Hormone suppression isn't usually effective for solid adenomas. Toxic ones causing hyperthyroidism might get radioactive iodine, but surgery is often preferred.
Okay, now for the malignant ones. Papillary carcinoma first. Most common thyroid cancer, right?
Correct. Most common thyroid cancer and most common endocrine malignancy overall. More common in females, any age but peaks around 40–50. Over 90% of childhood thyroid cancers are papillary.
Any risk factors?
About 5% have a history of neck irradiation, maybe increased incidence with Hashimoto's that's still debated. The link with Graves is also controversial.
What do they look like grossly when the pathologist sees the gland?
Size varies hugely, from tiny microcarcinomas under 1 centimeter to large masses, mostly solid, whitish, firm, often clearly invasive, but maybe 10–20% are encapsulated, look well-defined. Cystic changes happen in about 20%, cystic papillary carcinoma, and finding multiple microscopic tumor foci in the same gland is really common, maybe up to 75% if sampled extensively. Suggests both multicentric origin and spread within the gland.
And the microscopic features, what's the key diagnostic sign?
The absolute hallmark is the distinctive look of the nuclei, PTC-type nuclei. They're elongated, crowded, overlapping, pale or ground glass looking because the chromatin is dispersed. Often have irregular nuclear membranes best seen with special stains like emerin.
Ground glass nuclei, I've heard that term.
Yeah. You also see nuclear pseudoinclusions, bits of cytoplasm pushing into the nucleus and nuclear grooves like little lines or folds in the membrane. Mitoses, dividing cells, are usually scarce.
What else?
Extensive fibrosis is common, and about half have psammoma bodies, these small, round, layered calcifications. Seeing those strongly suggests papillary carcinoma. Electron microscopy shows more detail, indented nuclei, pseudo-inclusions, cytoplasmic features, abnormal basement membrane.
What about immunohistochemistry for papillary carcinoma, the staining patterns?
They usually keep the panfollicular markers like TTF1 and PX8 positive in the nucleus. Thyroglobulin is positive, maybe less intensely than benign tissue. TPO and NIS expression is often reduced.
Keratin.
Yes, positive for various keratins, typically CK7 positive and CK20 negative, often express CK19, which isn't usual in normal follicles. High molecular weight keratins too. Vimentin is often positive.
Any other key markers?
A panel including HbME1, galectin-3, CK19, cited 1, are often overexpressed compared to benign lesions. HbME1 and galectin-3 are considered pretty specific. CD56 is typically negative, mucin stains are often positive, and EMA, MUC1, on the apical membrane can help distinguish from benign papillae. But the utility of these panels can vary. Often the nuclear features are enough for diagnosis.
And the molecular genetics, this seems like a big area now.
Huge. Several key alterations. The most common by far is the BRAF PV600E mutation, found in 40–80% of classic papillary carcinomas and strongly linked to the tall cell variant.
BRAF V600E, that's targetable, right?
Yes, kinase inhibitors targeting it show responses in advanced cases. Other less common BRAF mutations exist, and BRAF's rearrangements are seen in radiation-linked cases. The prognostic significance of BRAF V600E is still debated. Some link it to worse outcomes, others don't consistently see that.
What else besides BRAF?
Rearrangements of the RET gene RET-PTC fusions. More common in kids and radiation-associated cases, less common if BRAF is mutated.
Okay.
Also NTRK gene rearrangements, NTRK1 or NTRK3. Found in up to 10%, similar features to RET-PTC, maybe more in younger patients in radiation cases. And ALK gene rearrangements are found in a small subset too. These might respond to ALK inhibitors.
What about the follicular variant? Does it have different genetics?
Yes, the encapsulated follicular variant, including NFTP, often has a RAS-like signature. NRAS or HRAS mutations are common. PPRG rearrangements, EIF1AX mutations, that fusion gene, different molecular pathway activation compared to the classic BRAF-driven type.
Yes, so several variants of papillary carcinoma exist.
Yes, based on morphology and sometimes behavior. We mentioned the follicular variant, mostly follicular growth, but with PTC nuclei, often RAS-like mutations. The encapsulated non-invasive form is now NIFTP.
Tall cell variant.
Yes, tall columnar cells, often more aggressive, high BRA V600E association. Columnar cell variant is also aggressive, tall cells with nuclei lined up at the base.
Any others stand out?
Cribriform morular variant, often encapsulated, mixed patterns, distinctive morals with biotin buildup, nuclear beta-catenin staining, WNT pathway active, often linked to FAP syndrome. Diffuse sclerosing variant, younger patients, diffuse gland involvement, lots of fibrosis in SAMA bodies, tends to be aggressive. Hobnail variant, cells can attach into colloid, looks like hobnails, also aggressive. Plus rarer ones, solid oncocytic, squamous, spindle cell, etc.
And NIFTP, non-invasive follicular thyroid neoplasm with papillary-like nuclear features. That's a mouthful, but important.
Very important. It's a reclassification of the non-invasive encapsulated follicular variant. The goal was to avoid calling something carcinoma that behaves extremely indolently, to avoid overtreatment.
What are the criteria?
Strict criteria: encapsulated or well-demarcated, follicular growth, 1% papillae, no seminal bodies, limited solid trabecular growth, specific papillary-like nuclear changes, score 2-3, no invasion, capsular or vascular, no necrosis, low mitosis. If all criteria met, recurrence risk is extremely low, 1%. Invasive cases are still called encapsulated follicular variant papillary carcinoma with invasion.
Huge implications for patients. How does papillary carcinoma usually spread?
Primarily via lymphatics. Cervical lymph node metastasis is early and common. Bloodborne spread is less frequent initially, but can go to lungs, bone, soft tissues, CNS, etc. TRT promoter mutations seem linked to higher risk of distant mets.
Treatment and prognosis.
Surgery is primary lobectomy or total thyroidectomy. Radioactive iodine ablation often follows, especially for higher risk cases. External beam radiation for advanced disease. Overall prognosis is excellent, especially for younger patients with localized tumors.
What makes the prognosis worse?
Older age, tumor growing outside the thyroid, extrathyroidal extension, certain aggressive variants like tall cell diffuse sclerosing, distant metastases, or finding areas of poorly differentiated or anaplastic cancer within it.
Okay, let's switch to follicular carcinoma. Diagnosis hinges on invasion, right? Not just the cells.
Exactly. You must see invasion into the capsule, blood vessels, or adjacent thyroid tissue to call it carcinoma. It's less common than papillary, affects slightly older patients, also more women. Iodine deficiency is a factor.
What does it look like?
Can be encapsulated either minimally invasive, just focal invasion, or widely invasive, extensive infiltration, no clear capsule. Widely invasive is rarer now in developed countries. Microscopically, it has uniform follicular structures, maybe with colloid. Crucially, the nuclei lack the PTC features of papillary carcinoma.
A molecular genetics of follicular carcinoma, different from papillary.
Yes, different profile. RAS mutations and RAS degrees are common, 40–50%, usually mutually exclusive with BRAF. POW3 KP10 pathway hits are less frequent than papillary. PAX-sic papagarg rearrangements are found in 30–40%. TERT promoter mutations in 10–20%, more in invasive tumors, linked to poor prognosis. BRAF V600E is rare. TP53 mutations can show up if it transforms towards poorly differentiated anaplastic.
Immunohistochemistry, does it help distinguish things?
These stain for the usual thyroid markers like thyroglobulin, TPO, TTF1, PAX8. Proliferation rate, Ki67, is generally higher than in adenomas. Markers like HbME1, galectin-3, CK19 might help distinguish from follicular variant papillary and IFTP, but again, variable utility. Aneuploidy can be seen in both adenomas and carcinomas.
How does it spread? Treatment?
More prone to bloodborne spread than papillary. Lungs, bones, kidney, skin are common sites. Bone meds can be pulsatile, vascular. Treatment is surgical resection, often total thyroidectomy. Radioactive iodine is used if the tumor takes it up, which can vary.
Prognosis for follicular carcinoma?
Minimally invasive has an excellent prognosis. Widely invasive is worse. Depends on extent of invasion, grade, stage, age. For encapsulated tumors, just capsular invasion has low metastasis risk. Vascular invasion carries a higher risk of distant spread.
And what about tumor of uncertain malignant potential, or FTUMP?
That term is used sparingly for encapsulated follicular tumors where invasion is questionable. WDT-UMP is similar, for non-invasive nodules with questionable papillary nuclear features not quite meeting an FTP criteria.
Okay, next up, oncocytic or Hürthle cell tumors, defined by those mitochondria-rich cells.
Yes, composed mostly, 75%, or entirely of oncocytic Hürthle cells. They have distinct characteristics. Tend to occur in older patients, less female predominance, often larger tumors at diagnosis, present at higher stages than non-oncocytic follicular cancers.
And behavior?
Lower survival rates overall, poor iodine uptake, limiting radioactive iodine therapy effectiveness, and patients have a higher rate of getting other secondary primary cancers later.
How do you tell benign adenoma from malignant carcinoma Hürthle cell tumors?
Adenomas are encapsulated, no invasion. They can even have papillary structures, but are benign if non-invasive. Carcinomas are defined by invasion, and they have a real tendency for vascular invasion. Lymph node mets are less common, but they can spread locally as nodules in soft tissue via blood vessels. Distant mets in about 10% at presentation, bone is common, can appear years later.
What do they look like grossly?
Often encapsulated, solid or trabecular pattern, more common than follicular. Carcinoma cells might be smaller with a higher nucleus to cytoplasm ratio. Even small Hürthle cell nodules can be malignant.
What's known about the molecular basis for the oncocytic change in tumors?
High rate of mitochondrial DNA mutations affecting the OXPHOS energy system, complex 1 and 3. Also mutations in a nuclear gene, NDUFA13, GRIM19, part of complex 1, seem specific to oncocytic tumors. These defects likely cause the mitochondria to accumulate, giving the oncocytic look, maybe making them sensitive to low oxygen. How this drives cancer is still being worked out.
Treatment and prognosis for Hürthle cell tumors?
Adenomas cured by lobectomy. Carcinomas are often aggressive. Prognosis is worse with older age, large size, extrathyroidal extension, vascular invasion, metastases. The extent of vascular invasion really impacts prognosis for encapsulated carcinomas.
All right, moving up the aggression scale. Poorly differentiated thyroid carcinoma, intermediate between well-differentiated and anaplastic.
That's the idea. Occurs in older folks, mean age 55–65, less female predominance. Grossly, often large, median 5 centimeters. Pushing margins, maybe satellite nodules, can look like widely invasive follicular or even mimic goiter.
Microscopic features.
Characteristic nesting or insular pattern small. Uniform cells in nests separated by thin vessels, often with artifactual clefts. Can also be solid or microfollicular. Mitosis are usually significant, 0.3/10 high-power fields. Tumor necrosis is common, often around blood vessels, peritheliomatosis. Nuclei are small, round, dark, maybe raisin-like, but no papillary features. Some have trabecular pattern or larger, more pleomorphic nuclei.
Are there specific diagnostic criteria, the Turin proposal?
Yes. Need nested solid trabecular growth, no papillary nuclear features, plus at least one of it, mitotic activity, 310 HPF, tumor necrosis or convoluted nuclei. Some can be composed of Hürthle cells too.
Molecular genetics and IHC.
Often show aneuploidy, lots of copy number changes. Molecularly distinct mirin A profile, can have mutations seen in well-diff cancers, VHOE, RAS, RETP, TC. TERT promoter and TP53 mutations also occur, but maybe TP53 less than anaplastic. PIK3, KKT1 mutations too. IHC, usually CK7 positive, CK20 negative, thyroglobulin reduced patchy, TTF1 positive, but maybe weaker. P53 might be increased. Chi-67 proliferation index, typically 10-30%.
Spread and prognosis.
Prone to distant mets, around 15% of diagnosis, and lymph node mets are common. Prognosis is worse than well-differentiated, better than anaplastic. Bad signs, tumor necrosis, high mitosis, distant mets, older age, extrathyroidal extension.
And finally, the most aggressive, anaplastic thyroid carcinoma, undifferentiated.
Highly aggressive, thankfully rare. Usually older patients, 6th, 7th decade, can arise from a differentiated cancer or de novo. Clinically, often rapid enlargement of a prior goiter, fixed to surrounding tissues, local invasion is common.
Microscopic patterns.
3 main patterns, often mixed. Giant cell type, large, bizarre multinucleated cells, spindle cell sarcomatoid type, elongated cells like sarcoma, and squamoid type, looks like squamous cell carcinoma, all typically have very high mitotic rates, extensive necrosis.
Key molecular changes in anaplastic.
TP53 inactivation is the most consistent finding. TERT promoter mutations, PI3Kp10 pathway alterations are common, often have copy number gains of genes like PIK3CA. Interestingly, they often also have mutations found in papillary follicular cancer, RAS, BRAF, suggesting they evolved from them. RET-PTC, PASAG, PPR usually absent.
IHC profile. Must be tricky.
Can be. Keratin positive in 50-100%. Fomentin consistently positive, especially spindle cells. Thyroglobule usually negative. Watch for false positives. TTF1, TTF2 positive only in a minority, but PX8 is positive in 70-80%, though maybe patchily. Diffuse P53 staining, reflecting mutation, is common. Chi-67 index is sky-high, around 35% or more. FNA cytology shows highly cellular smears, bizarre cells, necrosis.
Spread and prognosis.
Spreads rapidly. Nodal mets common, distant mets in 40-50% of presentation. Prognosis is dismal, notoriously poor. Median survival only a few months, 1-year survival maybe 10-20%. Death often from local neck disease. Better relatively if younger. Tumor confined to thyroid. Worse with acute symptoms like hoarseness, difficulty swallowing, breathing, rapid growth.
Okay, that covers the follicular cell tumors. Now, shifting to tumors from the C cells, medullary thyroid carcinoma.
Right, comes from the C cells, parafollicular cells, which make calcitonin. Can be sporadic, about 70%, or hereditary, about 30%. Hereditary forms are autosomal dominant, linked to germline RET mutations in syndromes like MEN2A, MEN2B, or just familial medullary thyroid carcinoma, FMTC.
What does it look like?
Grossly, solid, firm, non-encapsulated but circumscribed, grayish yellow cut surface. Usually the mid-upper gland where C cells are concentrated. Microscopically, nests or trabeculae of polygonal cells. Eosinophilic cytoplasm, often with amyloid stroma that stains with Congo red.
Amyloid stroma is key. Any variant.
Yep, papillary, follicular, small cell, giant cell variants exist. Electron microscopy shows those dense core neurosecretory granules typical of endocrine cells.
IHC markers for medullary.
Crucial. They're argyrophilic. Stain with silver, often mucin positive. Express keratin, TTF1, PX8 variable negative. Positive for panendocrine markers. Chromogranins, synaptophysin, CD56. Critically positive for calcitonin, though can be patch loss sometimes a pitfall. Also CEA positive. Negative for thyroglobulin helps distinguish from follicular tumors. Can express other peptide hormones too.
Genetics are key here, especially differentiating sporadic versus hereditary.
Absolutely. Sporadic cases often have somatic-acquired RET mutations, M981T most common, or sometimes RAS mutations, usually mutually exclusive with RAT. Rare RETOC fusions too. Hereditary cases have germline inherited RET mutations. These patients are younger, often have multiple bilateral tumors and associated C-cell hyperplasia.
C-cell hyperplasia, the precursor.
Yes, considered the precursor in familial syndromes. Can be diffuse or nodular proliferation of C-cells. Nodular form is more clearly a precursor. These hyperplastic cells often stain strongly for CEA and calcitonin. Need to distinguish it from early medullary cancer or reactive C-cell increases seen near the thyroid issues. Serum calcitonin CEA can be elevated in hyperplasia too.
How does medullary carcinoma spread? Treatment, prognosis.
It spreads locally to cervical mediastinal lymph nodes and distant sites, lung, liver, bone. Distant mets more common in sporadic MN2B. Treatment is surgical, total thyroidectomy plus lymph node dissection. Local recurrence around 35%, 5-year survival 70-80%. Doesn't respond well to radioactive iodine, radiation, or standard chemo. Tyrosine kinase inhibitors targeting RET show some success. Stage and age are biggest survival predictors. Small tumors found in prophylactic surgery for RET carriers have excellent prognosis. Better prognosis if young, female, familial, small, confined to gland. Worse with high mitosis, necrosis, squamous pattern, small cell type, poor calcitonin, high CEA staining.
Okay. The source also briefly lists other rare primary thyroid tumors.
Yeah, it just mentions things like mucoepidermoid carcinoma,
Hmm.
squamous plus glandular, sometimes papillary-like features, often with Hashimoto's, primary squamous cell carcinoma, rare, aggressive, neuroblastoma, very rare primary, intrathyroidal parathyroid tumors, need parathyroid markers to confirm. Also, non-cancerous things like amyloid goiter, malakoplakia, regions that can mimic tumors, and the thymic branchial pouch tumors near the thyroid.
Lymphoid tumors, lymphoma.
Primary thyroid lymphoma is uncommon, usually B-cell, MALD-ADIA, and hyperdiffuse large B-cell, strong link to Hashimoto's. Prognosis better from MALD type. Treatment, surgery plus adjuvant therapy. Need to distinguish from systemic lymphoma involving thyroid. Plasmacytoma, plasma cell tumor, can occur too, related to myeloma or solitary.
Mesenchymal tumors, connective tissue ones.
Very rare. Angiosarcoma, vascular cancer, controversial frequency, aggressive. Epithelioid hemangioendothelioma, low-grade vascular. Others like fibrosarcoma, liposarcoma, leiomyosarcoma, chondrosarcoma, osteosarcoma are exceedingly rare. Benign ones like hemangioma, lipoma, schwannoma too.
Teratoma.
Also very rare, usually congenital, benign, contains different tissue types. Thyroid tissue can be a component, usually normal or hyperplastic, rarely cancerous. Immature elements raise concern for malignancy.
What about tumors spreading to the thyroid? Metastases.
Uncommon as a clinical diagnosis, 0.2% of thyroid cancers, but found in about 10% of cancer patient autopsies. Can be direct extension from nearby cancers, larynx, esophagus, or bloodborne.
Most common sources for bloodborne mets.
Skin, melanoma, breast, kidney, lung. Usually solitary nodule, but can be multiple or diffuse. Can even metastasize into a pre-existing benign thyroid nodule, like an adenoma.
Any tricky mimics?
Renal cell carcinoma mets can look like primary clear cell thyroid tumors. Look for multiplicity, clear cytoplasm features, vessels, hemorrhage. IHC is key. Thyroid markers versus kidney markers. Metastatic adenocarcinomas, mucin stains help is intracytoplasmic. Need a good IHC panel. Thyroglobulin, TTF1, PX8 versus markers for other sites like CEA-specific keratins. Neuroendocrine cancers from elsewhere can also metastasize and mimic primary medullary carcinoma.
Okay, now some general features of these epithelial tumors. Geographic distribution, iodine link.
Yes, iodine deficiency is linked to higher rates of follicular and anaplastic carcinoma, and they tend to be more advanced in those areas. Iodized salt helps reduce this. Papillary carcinoma is dominant in iodine-sufficient areas. Some suggest high iodine might even increase its frequency. Overall pattern seems similar, east versus west.
What about thyroid cancer in kids, different from adults?
Mostly benign nodules in kids, adenoma, hyperplasia, but a higher proportion of nodules are malignant than in adults. Papillary is most common, then hereditary medullary, Hürthle cell. Molecularly, pediatric papillary often has RET-PTC or NTRK rearrangements, BRAF mutations less common than adults. Poorly differentiated adenoplastic are rare. Pediatric papillary often has solid squamous areas, high rate of node mets, but overall prognosis is excellent, though rare aggressive cases exist. Some have radiation history.
Radiation exposure as a risk factor.
Definitely. Low-dose therapeutic radiation in childhood increases risk of benign issues later. Nodules, thyroiditis, fibrosis, and papillary carcinoma. 20–50% risk in operated patients. Higher doses, like for Hodgkin's or Chernobyl, also increase risk. Post-Chernobyl kids' cancers often had solid pattern, RET-PTC fusions, but prognosis was generally good. Fukushima studies are ongoing. Familial non-medullary thyroid cancer exists too.
Okay, the big clinical challenge, evaluating the solitary thyroid nodule. Very common problem.
Hugely common. 4% of U.S. adults have palpable nodules, maybe 50% seen on ultrasound. 4 times more common in women. Goal is selective surgery for the malignant ones.
What factors are considered?
Age, higher risk in kids elderly. Sex, higher risk in males. Family history. Hashimoto's doesn't seem to increase nodule malignancy risk itself. Radiation history. Symptoms like hoarseness, vocal cord paralysis, number, solitary, maybe slightly higher risk. Growth rate, rapid is concerning. Enlarged neck lymph nodes, strongest clinical sign of malignancy. Thyroid function, hot nodules, lower risk. Ultrasound features, cystic spongiform, lower risk.
And investigations?
Fine needle aspiration, FNA biopsy, is the best non-surgical test for likelihood of malignancy. Molecular testing on FNA is increasingly used. But remember, even a solitary solid cold nodule is only 10–20% likely to be malignant. About a third of benign ones might even shrink on their own.
Core needle biopsy versus FNA.
Core biopsy takes more tissue. Useful for diffuse disease or advanced cancer, but less used for initial nodule workup due to risks, bleeding, nerve injury, etc. FNA is the standard for solitary nodules, quick, cheap, office-based, minimal risk, high accuracy, 90% for papillary, other cancers, thyroiditis, Main limitation is distinguishing benign versus malignant follicular neoplasms.
The Bethesda system for reporting FNA results.
Yes, a standardized system. 6 diagnostic categories, each with an estimated malignancy risk and management recommendation. Proven very valuable clinically.
Any complications from FNA itself?
Can happen. Partial complete nodule infarction, tissue death, especially in Hürthle cell ones, hemorrhage clotting. Rarely transient thyrotoxicosis from cyst aspiration.
Molecular testing on FNA samples becoming more standard.
Increasingly so, especially for indeterminate results. Helps identify benign nodules to avoid surgery, or cancerous ones needing surgery. ATA guidelines recommend it for indeterminate FNAs in certified labs. Gene expression classifiers, GECs, aim to rule out cancer. Mutation panels, like ThyroSec, look for specific cancer-driving mutations. Performance depends partly on pathologist thresholds, especially for NFTP follicular variant papillary.
What about frozen section during surgery? Still used?
Sometimes, but less often now with better FNA molecular testing. Can help confirm invasion or node mets. Tricky with renals, diffuse hyperplasia, sequestered nodules. Most common uses during lobectomy for an indeterminate nodule. Adenoma versus carcinoma versus hyperplasia. Experienced pathologists can spot obvious cancers, anaplastic medullary, widely invasive follicular, classic papillary. Harder to assess minimal invasion or subtle papillary features on frozen. High rate of deferred to permanent sections. Most lesions treated effectively by lobectomy anyway.
Okay, a couple unusual situations. Sequestered or parasitic thyroid nodules.
Rare. Thyroid tissue detached from the main gland, usually nearby, can mimic metastatic cancer in a lymph node, especially with Hashimoto's changes.
Thyroid tissue elsewhere. Mets presenting first.
Metastatic papillary cancer in a neck node can be the first sign. Primary might be tiny, mostly females. But not all papillary mets and nodes are from thyroid. Consider other primaries. And thyroid tissue can be in teratomas elsewhere, like ovaries, stroma ovari, can be normal, hyperplastic, rarely cancerous there.
Finally, the overall prognosis for well-differentiated thyroid cancer, papillary and follicular.
Generally excellent. Older staging systems had low versus high risk based on age, sex, with big survival differences. Later systems refine this. Most thyroid cancer deaths are from the aggressive types, undifferentiated, poorly differentiated, Hürthle cell, medullary. Encapsulated and well-differentiated follicular pattern cancers don't significantly impact mortality. Lymphomas, mesenchymal tumors, metastases are other considerations we've touched on.
Wow, that was an incredibly thorough deep dive into the thyroid. Everything from its development right through to, well, some pretty scary cancers, but also a lot of benign conditions.
It's a complex little gland.
And that needle in the haystack analogy really holds up, doesn't it? Nodules are everywhere, most are fine. But the careful evaluation we discussed, clinical factors, imaging, FNA, now molecular tests, it's all crucial to find that small percentage needing specific action.
Absolutely. And the field is constantly evolving, like with NIFTP, trying to get the diagnosis and treatment just right, avoiding overtreatment.
It really highlights the progress. What stands out to me, wrapping this up, is that constant interplay you mentioned throughout genetics, environment, the immune system, all converging on this one gland.
It's fascinating.
Yeah.
And it leads to a final thought maybe for you listening. How are these powerful forces, our genes, our exposures, our own immunity, interacting in ways we're maybe only just starting to grasp?
Yeah.
And what could that understanding mean, not just for future medicine, but maybe even for how we think about our own health journeys?
That's definitely something to mull over. A great point to end on. Thank you for joining us for this very deep dive into the thyroid. If you have sources you'd like us to explore in future episodes, please send them our way.
We'd love to see them.
Until next time, keep asking questions, keep digging deeper.